Hi, everyone, and welcome back to Office Hours. This is the series where we step outside the slide decks and into the real world stories shaping the revenue cycle. And I'm your host, Stuart Newsom. Today's episode is all about a function that rarely gets the spotlight, but quietly holds the keys to your revenue, and that is credentialing and enrollment. So, our topic today is why credentialing breakdowns are costing radiology groups millions. And we're thrilled to be joined by not one, but two powerhouse guests. So we have Rebecca Bairnsfather. So I hope I pronounced that correctly, Rebecca.
Yes.
Um, yeah, she's a manager of provider enrollment here in Phoenix Healthcare. And then we have Peggy Kelly, who's Senior Vice President of RCM Operations. So these two bring decades of experience managing credentialing operations at scale. They working with radiology groups and even hospitals and multi-state health systems. So they've done it. They've been on the front lines with, gosh, payer negotiations, provider enrollment bottlenecks, recredentialing nightmares. So you name it, they've lived it. So how y'all doing?
Great. So excited to be here.
Awesome, awesome. I'm excited to have both of you on to share this expertise. This is such a hefty subject, it needed two guests. So I was thinking about that this week.
Well, Rebecca
So,
is the star of the show for sure. She has seen just about every equation from a credentialing standpoint in this industry.
awesome, awesome. So, well, today we're digging into the disconnect between how credentialing is treated. And I use that word intentionally. Sometimes it's treated very badly, and how it actually functions. So, it's often seen as administrative noise, but in reality, it's the reason your claims get paid. It's the reason your providers get in network. And it's also the reason your audits stay off DEFCON 1, so to speak. So we'll unpack where credentialing workflows go wrong, why payer behavior is making everything harder, and what you should expect from your tech platforms, as well as your staff and operations leaders. So as always, we're going to save time at the end for questioning. We do have a Q&A, but not just questions, but you can feel free to put in some comments. So we have a little Q&A box that you can click on and drop in your questions and comments there. So with that, y'all ready to get started?
Absolutely.
Sure
All
thing.
right. Well, first off, and either one of y'all just chime in. I'm not going to call on any names or anybody, say take the front, but just feel free to have the conversation how you want. But just want to level set a little bit for everyone and discuss what's the difference between credentialing and payer or provider enrollment. I know a lot of people use the terms interchangeably, but they're not exactly the same. So can you break it down for us?
Yeah, absolutely. Yeah, people seem to think they are the same, the credentialing and provider or payer enrollment, however else you want to say it. They're both separate, but they're connected steps. I mean, to me, credentialing is about verifying your provider's qualifications, his education, his licenses, his work history, his malpractice history, reviewing all those claims as well. And sometimes when I hear the word credentialing, I think more on the hospital side and their verifications and their CVO and all those checks and steps that they go to be permitted to be submitted to their board approval. So on my side, which is more geared towards the payer provider enrollment, those are the steps and applications that you submit to the individual payers to get them in network with the various plans and to pay at that group tax ID level. So the process is very different, but again, connected. And I want to mention about hospital-based providers. Those are your emergency, your anesthesia, pathology, hospitalists, and your radiology type providers. When you're submitting stuff to payers, a lot of payers would tell you those provider types don't necessarily need full credentialing, and that's because they've already been credentialed on the hospital side. But there's still another step that we need to take to link that provider to the correct group so billing can happen and route to the correct tax ID and pay to. So it's not like I can't just say, hey, new provider here and there. They still need to know a provider exists and where to pay to that claim to as well. multiple steps in this. And I want to mention that also depends on type of contract sometimes. If you have a facility agreement that includes professional type services, some payers will say, hey, we're just pay at the tax ID level. We don't even know a provider needs to exist. And it varies between the different payers. So your contracts can look different across that board. So yeah, different, but still very much connected. So that's kind of my
Right.
take on it.
So they intertwine with each other, definitely.
Absolutely.
Yep. Cool. So let's start with the basics, you know, after that clarity, you know, so why do you think credentialing still gets treated as an administrative checkbox, like just something we're just going to check off the list and move on,
Oh,
rather
yeah.
than a core piece of the revenue cycle?
Mhm. Definitely, because I think because it happens, the work and the process happens so early in the beginning before you even get to submit that claim, it's so much overlooked and how much prep and time goes into that. I mean, the starting line of your revenue cycle for whatever you're doing at facility level, small provider group, large group, that is the first step. Long before the money even starts to flow in. Um, if they're not credentialed correctly or contracted, or the reimbursements aren't right, you're going to see that loss of revenue, and you don't want to see that. So I say when it works well, it's invisible.
Right.
Right. And people just don't realize that. But when one thing goes wrong, everybody notices it and everybody feels it. So
It's kind of being worked on in the background while multiple other things are happening and seem to rise to the top in order of importance.
Mhm.
Kind of forgetting that huge sort of clerical, most important process of the revenue cycle.
Mhm.
Yep.
It is the most important process of revenue cycle.
Right,
Yeah.
because I think if you get that wrong, everything else downstream is going to be wrong.
Exactly right.
Absolutely. It's trying to protect your ability to bill and collect the whole time. I mean, it's the core part of the revenue cycle. So it's not just, you got to shift that mindset from just being paperwork and you're pushing those applications to, it is the first step of getting paid and getting the right reimbursements. So again, about protecting that revenue down the line.
Nice, nice. And so in our prep for this call, you mentioned how credentialing often stalls because of a payer-driven delay. I mean, who would have guessed that, right? As I say sarcastically. I mean, it's pretty much, you know, the whole, you know, bane of their existence in a lot of ways. But it's not necessarily the internal ones, you know, where there's a lot where the RCM team maybe gets the blame, maybe the physician gets the blame because lack of documentation. Coder may get the blame because they're not
Mhm.
coding it as fast as they need to. But can you walk us through what that looks like day to day and why clients often misplace blame and where that blame really needs to be?
Oh gosh, that is something that just comes up all the time with clients, especially clients new to the world, a new tax ID, new contracting. I mean, they seem to think that we're just sitting on things, we're not working, or things are just moving too slow. But like Peggy said, there's so much happening behind the scenes with trying to get the payer packets. And first step is contracts sometimes, if they even allow the contracts, if the network's even open or closed. So the payer packets and tracking down signatures, and we still have to do verification checks as well, and getting everything off. And a lot of stuff is still done manually, manual applications. And then we have to jump into the different various online portals and submit those applications well. There's many steps happening that the client doesn't see up front. And a lot of times, you know, once we get that submitted and in out of our hands to the payer, it's out of our control. I
Mm,
mean, some payers sit on those applications and don't acknowledge receipt until 30 days. They're just sitting in their queue for weeks and months. And
mm,
then they come back to us and say, oh, well, we might be missing this, or can you resend this, which happens all the time. You know, sometimes our submissions have several documents attached. Well, we don't see this one. Well, it is there. It's there for you. It just jams up the process. So those time frames just extend on and on and on. But they have to understand, if I'm submitting an application, say one provider that joined a group or established group or new group, I'm possibly submitting 15 to 20 different applications for the payer.
Mhm.
And if I have
Right.
multiple providers, multiple payers, and you can see how that gets so large if you have large groups and multiple providers at times. I mean, you can be looking at thousands and thousands of applications. So I can understand how they think, what's going on, this and that. It's it's difficult. You got to gather that information, make sure all your checks are in place, get it out to the payers, and then you have to sit and wait for them to process. And that's where it jams up your time frames. And yes, a lot of times we look quiet to the payer, to the client, I'm sorry, but
Mhm.
behind the scenes, we're following up, we're checking statuses, we're pushing out those updates, and we're trying to troubleshoot any issues that come up. But we're also trying to keep up licenses and certifications and everything else in the meantime. So that's
Right.
kind of what
Right.
our day to day, and that's what kind of just jams up that process sometimes.
Right. And I would imagine is the same payers that are typically slow and delays
Repeat offenders,
are,
yes.
are the culprits. I mean, if it's
Oh, yeah.
yeah. So so you could probably pick them out. I've always said there are your payers that are just bad actors. They
Oh,
just
yeah. Mhm.
they just don't want to play. And I'm often wonder, are they worth it? Is our revenue stream from that payer even worth it? I know it's bad for the patients, but I've known some groups who will just say, "Hey, we're just going to take a look at our top 5, 6, 7 payers, and if they fall below a threshold, it's just not worth our effort and time to even be enrolled with them." So, but
Yep.
it's radical thinking, but
Yep.
and
Same
again,
thought on
yeah,
same thought on that if the contract reimbursement is not right. If they
mhm,
really lowballing you on that, you have to ask your question, is it even worth it contracting? Or
right,
do you take
right,
your out of network rate as well? That's something
exactly,
that we consider in a lot of our new contracts with brand new tax ID.
Right, right, especially with a brand new tax ID.
Mhm.
Because if
mm,
they don't necessarily need you in their network, they will just lowball you.
Yes.
oh wow. Wow. Well, and I imagine it's even harder when you're crossing state lines, which
Mhm.
kind of comes, to the next question that I
Mhm.
have is, radiology groups aren't small anymore. So
Mm-mm.
some of them have thousands of providers across dozens of states. Um, what happens when you add that kind of scale and complexity to everything you just talked about? What are the things most people overlook?
Oh, wow. I mean, the sheer volume of work is just enormous, to be honest with you. Doing hundreds of providers across state lines, that many payers, applications, and tracking is insane. Um, you just,
In particular, if it's non-delegated.
yes, delegation brings in a whole nother separate set and how
Mhm.
things act and work, and which can be really good at times, especially if you have over 50 providers in a group.
Exactly.
Delegation is the way you want to go, but you have to have your internal NCQA type auditors in place for that
Mm,
facility for that even to be applied for a delegation. But what we're all speaking to is, all non-delegated,
Right.
submitting to every single payer and trying to manage
Yep.
that type of scale is very difficult because one small delay can just mess up everything. One missing document, one backlog, one signature takes too long. I mean, it could just ripple through the whole process. So,
wow.
and of course, it's pushing back your start dates, and it's just putting everyone at risk at this point. And
Yeah, you don't want to give them a reason, right? To
And
to
correct.
delay things. So
and linking to the multiple tax IDs that often come with these
Mhm.
very large groups. So you're duplicating, triplicating all these efforts based on tax ID
right.
for hundreds and thousands of providers.
Mhm.
Yeah, it's
Yep.
crazy.
And they seem to overlook when you step into the different states, every state has their different payer landscape. It's not the same as, I'm more Louisiana driven here. When I step into Texas and Mississippi and wherever else, the payer landscape is completely different. And it's different. A lot of their state Medicaids are different. Here
Mhm.
we have 6 managed Medicaid plans. Alabama has none. You step into Florida, those management, there's over 20, and these all vary by county. Where your practice location sits determines what payer you get in for that county. It's just massive. So, and then I think the ongoing maintenance is also overlooked. I mean, again, all about the tracking the expirables of the licenses,
Right.
and the roster updates, the recredentialing, and keeping your CAQH updated. It's a lot, and I can see how it's enormous and very difficult to manage, in which it is. And
Yes.
just underestimate how crucial it is to plan and have good communication with the client as well, and be realistic about timeframes and just lay it out on the line that this is what's going to happen, just keeping everyone aligned.
Yeah. It's the phrase herding cats comes to mind. So
Yeah.
you're just,
Yeah.
yeah. So, well, and, to the next question here, we've heard, some of these large groups will try and get creative to their own detriment. And such as they'll route claims through the quote unquote best contract, by using different tins. So, kind of a rhetorical question, but is that a red flag, a necessary workaround, or is it something in between?
I'm gonna say it's common for the large groups to have multiple tax IDs, like when they're acquiring different practices and operating in different regions, and they have different type of payer agreements. But trying to build to the one that has the strongest contract and not having the proper checks in place, making sure the provider is fully credentialed and linked to that certain TIN and location, can be a red flag. You can't just say, oh, this provider goes here and I want to route this claim under this tax ID here. It doesn't work that way. You still need to make sure you're in compliance with the contracts themselves and the payers, and that your providers are linked properly and credentialed. Uh, if it's done right, I think it'll be okay, but
Mhm.
just choosing it for the higher reimbursement is not. So, and then and just managing the nightmare. I mean, I know Peggy probably speak to that on the billing side. How do you route what claim, what, where, what tax ID, this and that? I mean, how would that
Right.
managing that?
That's where a lot of the tech flow has to come into play when you're trying to push a claim to a different channel. Does that involve a separate tax ID in a separate accounts receivable, right? If you're running your accounts receivable by 10, are you pushing to a national contract? Maybe you've got one payer like United Healthcare that you have a national contract with, and all your TINs roll up into that. Well, then again, what's the architecture of your billing system, and how do you want to see that roll out and flow out? Do you want to look at those numbers separately? Do you want to keep that United work in one, AR based on all the tax IDs rolling into one national agreement?
Mhm.
So there's lots of variables, and of course, the contracting is what's really important and what drives it, and the language within all of those contracts, per TIN.
Mhm. So it all has to really map out. I mean, you
Yep.
can have the
It's
best contract in the world, but
strategic mapping
yeah,
is
yeah,
great. Yes.
yeah. So it's
Yeah.
all got to be linked together, so to speak. You got to connect the
E-
dots.
Exactly right.
Yeah,
And
yeah,
with the No Surprise Act that's now in place, I mean, you got to be very careful with that.
right, exactly. So, and then speaking of tech, we know that there is credentialing software, out there. And so, with that said, um, how does this software help with these complex workflows? Is tech the answer, or does it still come down to expertise and follow through?
This is something that we have struggled with. We've come from a background where we were tracking everything on Excel spreadsheets, and you can understand how large those spreadsheets can be with no tickler of giving us information for tracking. So we went down the line with several different products. We've tried MD Staff, Echo One app, Credential Steam, Credential My Doc, and honestly, I think they all just fall short in what we do in regards to payer provider enrollment. I mean, those systems are great in helping you organize and do document retention there and tracking information. I mean, they can all do the same basic stuff like flag the expirables and like licenses and malpractice and things like that. But I think where some of the limitations show up, there's not a workflow and built into these systems for what we do on the payer provider enrollment side. I think most of these large systems are built towards hospital verifications and their CVOs and their border pools. That's how I see them. It's just really just one little separate carve out for payer enrollment, you know, where I just drop an effective date in a payer. It's not giving me that detailed workflow where I have my steps, where I'm in my prepare, my submitted, and my finalized step, and I'm tracking, and I can set a task for, you know, to follow up and this and there. They fall short in that. It's just not there. And a lot of systems don't have a true onboarding platform either. We're still working on sending, I want to say, paper packets to the providers because we still have some payers like our state Medicaid that requires that original wet signature to be mailed into Medicaid instead of taking the digital or a written signature. So we still have packets being mailed back to us here in the office that we still have to mail off. You would think some of that would have changed during the COVID time, but not. It has not.
Right.
So, and a lot of systems don't fully integrate with CAQH. You know, CAQH is out there and paid for by the payers. So they don't really want to talk to these third-party platforms and try to do the integration. So if integration with CAQH was built in, it would be much easier. So we're not entering the same data 3 times, one in the platform, one on the application, and then one in CAQH, you know. Is that where the tech needs to come in? Yes. I know there's applications out there that do the form mapping. It's better than nothing, but it's difficult because a lot of those platforms only map, say, 5 to 10, and then there's a fee after that to do the mapping, or it's still not correct. And it gets pushed back on me to try to figure out the mapping. And it's just difficult and time consuming. So do I think tech might be the way to go and to build and develop? Definitely. But we need to hit on the core pieces, which is the onboarding, the CAQH integration, build in the digital signature capture as well, the mapping of the forms and things like that. But ultimately, end of the day, the specialist still has to touch that workflow and to make sure everything is being done, because they still have to pick up the phone or send the emails and do the checks to see where we're at in this process. And that's where your experience and your people come in. So can it sit out there all the text? I don't know. Someone still needs to touch and go through that process.
Yeah, there's just too much at stake, you know, it downstream. I mean, there's just a lot in there's a lot of investment, not just in, you know, the revenue that's being billed and where that's going to go, but also in the actual resources that you have, human component. Talking about the providers, even talking about the staff. There's just so much at stake that this is so important. So you both talked about working in states like Louisiana, Florida, Texas. What makes credentialing especially difficult in certain states? And you kind of mentioned maybe it's you know, Medicare managed care or Medicaid entities. You know, how do you stay ahead of that?
It's difficult working in states that you haven't touched before. To me, it's just comes down to 2 things: how complex and how different the payer landscapes are, and then how strict those state requirements are as well. With, like I said, we mentioned in Florida, and I know New York, they have so many Medicaid managed plans that vary by county, by location, that you have to research every payer to figure out and ask those various plans, can you get network, if you're even allowed to get network, because there's so many strict limitations, even on the specific, on the specialty, or we already have enough of those people in our type of network. They'll tell you that we're good, our network's closed, you know. So, and then it comes to the more state requirements. In Louisiana, for our state Medicaid, our providers and owners do not have to be fingerprinted in background. It's not a requirement. You step into Florida or Alabama, every single provider. And if you're an owner or have any type of ownership, they also have to provide fingerprinting and background. And that, again, that's jamming up your process because you're submitting the application. It sits over there for so many days. Then they come back and say, oh, okay, I think we're going to approve you. But, here's a form for your provider and your owners to take to the nearest office to go have your fingerprint background done. Okay, schedule an appointment, go do that, and then wait for that form to get back to the payer for them to finish their processing. It's crazy the difference and why it's not the same. I mean,
and the other thing too, that I know it's not always, the worst thing, I guess, but it can be terrible for you, Rebecca, and your team, but the disenrollment, those Medicaid plans that disenroll our providers because of inactivity for a specific period of time. If you don't file a charge in 6 months, they, like Texas Medicaid,
correct,
disenrolls. And you don't know this until another claim drops.
Well, yeah, of course you don't.
It's a disconnect, right?
and that's
Yeah.
And that's standard for Medicare as well. If there's no billing within 12 months, they'll send you just straight up termination letter, send our state Medicaid here. And I'm pretty sure that's probably in standard contract from a lot of them. If there's no billing, they're going to assume that you're inactive. But you see, like Mississippi Medicaid and Alabama Medicaid, once a provider is enrolled, you're not done and just wait for recredentialing. I have to submit an updated license every single year. Even though they're not within a recredentialing period, I still have to send the license in and check that they got it and processed it. So keeping up with that as well, especially when you step into other states, they want those license updates all the time. So to how to stay ahead of some of this, basically do your homework. I mean, unfortunately, it does take a lot of time to research and do that homework, but we started that we can try to start tracking what information we find per payer and put it on our sheets and try to, and keep track of it. But again, it goes back setting clear expectations with the client. And like, hey, before you do this, you might want to check this and that type situation. So it's difficult when you step into other states, especially if you don't have those payer relationships and those provider relationships and not familiar with the process. I can see how it's very hard to do.
Wow. Yeah. So last question from my standpoint, and then we're going to go to the audience. So this is definitely the last. So, and we know COVID changed a lot of things in healthcare and how care is delivered. And one aspect was telehealth. Teleradiology especially added a whole new wrinkle. What's your take on where those rules are heading and how credentialing teams should prepare? Because telehealth was quite different before COVID. Then during COVID, it was a whole nother animal. And now it's kind of still trying to figure out what it wants to be when it grows up, right? So just want to hear your take on that.
Oh, it's definitely added a whole layer of complexity for us. But it's a convenience that myself and family have used with the telehealth. I mean, it's very convenient and I like it. I could do it on my off hour, I could do it in lunch hour, whatever. It's easy to do. I don't have to get in the car, drive, or wait forever for an appointment. I think it's going to continue to grow and more groups are going to offer more of these remote type services. And same thing with the teleradiology. I'm pretty sure that just like Louisiana, we have shortage of certain provider types, and radiology is one of them, like anesthesiology. They might have to reach out for providers and groups or locum type companies outside of the state. And that's where your teleradiology is going to pull in through. Now, those requirements, they vary. I mean, CMS has a strict requirement right now that we're within the telehealth waiver is what they call, that goes through the end of December of this year, where we don't have to report a provider's home address on the claim. But if that waiver technically ends for telehealth and teleradiology, we're going to start submitting applications where the provider sits their home address to that state MAC, the contractor, and include the provider's address on the claim.
As the practice location.
Yes. I mean, you have to consider how much that's going to impact the provider. How do you think they're going to feel knowing that a patient could request a copy of their claim to review or their EOB and only to see their personal home address listed as a place of service? I mean, that's just uncomfortable all around, and to me, a serious privacy concern as well.
Yeah.
My feeling is that I think we're just too far down the road with telehealth and teleradiology, and it works. It
Mhm.
truly works. That
Yeah.
I just think that there's a lot of initiatives out there right now, working through this. I do think it's going to be here to stay. Will not from a radiology perspective necessarily on rates, but office visits. That's maybe where we might see some change is in reimbursement on the office visit when the patient is in their home.
Right.
Um, but I personally don't see it just going away and expiring. I
Mhm.
just, it's too far gone. It works.
It works.
Yep.
So, and the radiology thing in particular with the national shortage of radiologists, I just, I don't see them kind of going backward on some of those requirements.
Yeah, the proverbial toothpaste is out of the tube, so to speak. Yeah,
Yes,
you
and
can't put it back. So, that's for sure.
that is
All
good.
all right. Well, I'm going to turn it over to Q&A and comments. So if anyone has a question, please enter it in the Q&A. We'll be happy to address those. I don't really see any. Yeah, here comes. Okay, I have a question here. It says, we're a mid-sized radiology group trying to expand into 3 new states. Wow, we're just right on that subject. So what's the best way to get ahead of payer restrictions and avoid delays during that kind of expansion?
Well, it's really smart to think about this before you start expanding into other states. Because like I mentioned, the payer restrictions and the state rules, they're going to vary. And it can slow you down if you don't know what to expect. You need to look at those states you're moving into. Like I said, every state has their own payer landscape, see which ones are the primary high most used in each of those states. I would check out their state Medicaids as well. Do they have MCOs, not MCOs? Do they vary by the county, like I mentioned before? How many practice locations when you step into those states are you looking to do as well? Just one or multiple? I mean, all that's going to drive everything you do. What I would suggest to do, what we do now, we reach out to those payers in advance and say, hey, we have this group. They're currently located here. They wanted to step into the state. We introduce the group. We explain what our plans are, future plans. We ask about their network availability and their process. And we try to figure what potential roadblocks we might have with that. But it's important to know that your credentialing and billing and operations teams, they all need to be aligned, because again, it's going to drive out your payer timeframes, and it's going to be a while before you submit that first claim out of those, when you're stepping out of those states, before you get that reimbursement in. So do your research, do your homework. That is the best way to kind of stay ahead of that.
Awesome. All right, now here's a good one. Are there any KPIs or benchmarks you recommend tracking to actually measure how well our credentialing function is actually performing?
Yeah, I mean, to me, the most important is the time to complete enrollment. From the date you receive a complete signed packet in your hand to the date you get your approval letter is how you're going to track how far or how long a payer is really taking. Now, when I say that, there's probably going to be some problems before you get your signed packet. Being a signature slow provider out of the country happens all the time, but that's a big one there, and it can cause a lot of bottlenecks. But another one I would say, like your first pass approval. Okay, submitted this application, nothing kicked back to me, nobody came back and asked for anything like that. That's great. Straight first pass approval. That shows that your team is pretty well versed in what they're doing. And if they've got a lot of kickbacks, then it shows that I need to sit with them and see where training might be needed if we have a lot of stuff coming back to us. Maybe tracking your recredentialing and expirations compliance rate as well. You want to stay on top of those, because if you fall out of network, you got to start all over again, submitting just like an initial application type situation. And I also like to track the lag time. I'm taking out where I received the payer packet. When I say lag time, from the date I submit from the payer to the date I receive the approval, tells me the true lag time of the payer processing time right then and there. And that's where we need to do a better job myself, tracking by payer, by state, what those times could be. And that kind of goes back to the software question as well. That's a feature that's not built into a lot. Capturing my submission, capturing my date that I received the approval, which is usually varies in a different date than the effective date. So I can build that and see it within my dashboard and those lag times. So somebody can say, hey, how long is Medicare taking? Oh, they're running about 60 days right now, and we can see the difference as time goes on. So that's a really good one to track as well. That would be my favorite probably.
No, awesome. Awesome. All right. Well, any closing thoughts? Any before we wrap things up? I know it's this was by far one of the most important office hours I think we can do, because this is where the RCM
Absolutely.
process starts.
Absolutely.
Yeah.
Critical.
Yeah.
Critical.
It's just not, like you said, administrative task. It is essential to the whole revenue cycle system. It does get overlooked. A lot of people are just not educated on what the credentialing enrollment is. A lot of doctors themselves would tell you, I have no idea what I'm doing. They don't know. This is not taught to them when they're in medical school.
Right.
They don't know this side. We are educating them when they call us, telling them this is what you have to. We have to tell them how to apply for an MPI sometimes. They have no idea. It is a big step that is over. It is just missed all around, but it is most important in the revenue cycle step.
Right. And strong communication between revenue cycle and your credentialing enrollment team is huge.
Yep. Having that communication with your billing team. I always say to my billing managers here, is that billing team is the first line of defense for me when there's non-par denials, because then I can jump on it, figure out what's going on before recoupments start happening. And then sometimes that just gets way out of hand. So that open communication with your billing team is very, very important.
Awesome. Awesome. Well, I want to thank both of you, Rebecca and Peggy, for joining us today. It's been awesome. We will definitely have you back on. So
awesome.
We'll mark your calendars. So, and I want to appreciate everyone else for joining us on this episode of Office Hours. As always, you can find us at infinix.com for more information. Feel free to reach out to us. We'd be happy to have a discussion with you about our solutions and also continue the discussion that we talked about today. So please reach out to us. Till then, we'll see you next time. Thanks for joining us.
Thank you.
Thank you.